Thank you, Chairman, for your kind words to introduce me. So the topic of my presentation is pulmonary denervation across the spectrum of different etiologies of patients with pulmonary hypertension. I will go through from the current evidence to future perspectives. This is my disclosure. So basically, we tried to get the location of PA sympathetic nerves around the pulmonary tree. From left to right, you can see once we finish 3D reconstruction, so the nerve's main trunk localized at the left lateral wall of main trunk of pulmonary artery. Once it reaches to the distal bifurcation area, it will divide into two branches, one from the posterior wall of left branch, another from the posterior wall of right branch, to concentrate to run to the distal tiny vessel. So in the middle panel, you can see the shortest distance from the nose trunk to the intima of pulmonary artery is shorter than 1 millimeter. I think this is very important anatomical finding to encourage us to divine, to innovate the percutaneous device to treat pulmonary hypertension. On the right panel, we did find similar findings about the anatomy of PA sympathetic nerves from human body. So there's no doubt about the wide spectrum of the distribution of PA nerves around the PA pulmonary tree. Also, we tried to use the TH staining as well as the CGRP to identify the components of the PA nose components. So basically, from the red color, so it means greater than 99% of the fibers are sympathetic features. So nextly, we perform our first animal study. We're using the coronary artery balloon to occlude the anterior blood from the distal base trunk to the proximal interlobar level to see if there is any further increase in pulmonary arterial pressure. Particularly, when the balloon localized at the proximal level, close proximal to the interlobar level. So from the middle panel, you can see by 2 minutes continuous occlusion of the coronary balloon. So the PA pressure increased very much until to 5 minutes. There was no second increase of the pressure. It means the increase of PA pressure is limited. But on the other hand, when we localize the balloon at the very distal, close to the basal trunk, there was no further increase. Simultaneously, we performed PA ablation at the level 1, 2, and 3. It consists of the bifurcation area level. So after that, so the further occlusion of the blood flow did not result in the further increase of the PA pressure. I think this is very, very important preliminary finding from acute model. So after that, we create and studied the efficacy of pulmonary artery denervation in chronic pulmonary hypertensive animal model. We use a beagle dog randomized to test and control group of the injection of the DHMCT to induce the pulmonary hypertension. Once the mean pressure greater than 25 millimeter mercury, so animal would be further randomized to PADN group pulmonary artery denervation as well as the sham control group. So from the middle panel, you can see compared to the sham group at 3 months follow-up. So I think the vascular lumen in PADN group looks like pretty large with very mild proliferation of the smooth muscle cell. I think this finding is very consistent with the finding from electroscopy. We also measure the conduction velocity of sympathetic nerve cells as shown on the extreme right panel. You can see at 1 month, so the conduction velocity was decreased by 85%. There was no further rebound, no further regeneration of the sympathetic nervous, as showed no further increase of conduction velocity, as well as very significant demyelization by 2 months follow-up from the electroscopy finding. After finished the 3 animal study, so I think the next step was a very careful design of individual but sequential clinical trial. We studied from PADN1 phase 1 clinical trial. It's also called FAME trial. After that, we designed the second PADN1 phase 2 study, followed by PADN5, PADN CFDI, PADN PH-LHD, as well as the post-heart failure multi-center randomized clinical trial. Basically, back to 10 years ago, so this is a brief introduction of the study flowchart for PADN1 phase 1 clinical trial. We only included 21 patients with idiopathic pulmonary arterial hypertension who were refractory to specific medications. So then patient grouped to PADN group with 13 patients included compared to the control group with 8 patients. It's not randomized study. It's just a film study. So we monitor the change in 6-minute walk distance, hemodynamic and cardiac function change at 3 months follow-up. This is a striking clinical study. Next, a multi-center randomized sham-controlled trial is a PADN CFDI. We also included patients with group 1 pulmonary arterial hypertension. So patients randomized to PADN plus PDE5 inhibit compared with the sham procedure plus with the PDE5 inhibit. So the primary endpoint was a 6-minute walk distance change at 6 months follow-up, but we also extended our clinical follow-up until 2-3 years. Basically, for the primary endpoint on the right panel, you can see by 6 months follow-up in the sham group, after very short transit temporary increase in exercise capacity in the sham group, after 1 month, it tended to gradually decrease significantly compared to the gradual increase in the PADN group. Finally, by 6 months follow-up, the absolute difference in 6-minute walk distance between two groups was 33, almost 34 meters. So according to the FDA policy, so for any given treatment, any given follow-up timing point, so the absolute increase in 6-minute walk distance greater than 30 meters. So it means the matter of significant difference. Again, on the left panel, you can see by 1 year follow-up. So after 6 months, so the exercise capacity in the sham group further reduced to minor value, even lower than the baseline value before the randomization. Still significantly different to the slowly but still gradually increase in the PADN group. I think this is a very similar finding to be consistent with the finding from Stella trial using sotatercept for patients with group 1 pulmonary arterial hypertension. These are only 2 studies we included patients with group 1 or idiopathy. So from the PADN safety trial, we also got a very low rate of clinical worsening defined as a cardiac death, heart failure rehospitalization, worsening of pulmonary hypertension for outpatient. So it was only less than 5% in the PADN group compared to 23% in the sham control group. I think this data is also very important to guide our next design of clinical trial. Following that, we did our PADN1 study phase 2, because once we have finished the film study, we try to get the effectiveness of PADN for different etiologies of pulmonary hypertension. This is our study. So we follow up 66 patients with different causes of pulmonary hypertension after pulmonary denervation and completed 1 year follow-up. So the components of pulmonary hypertension including group 1, 2, and 4. It means it's a pilot study, but including most of patients with different etiologies of pulmonary hypertension. From left panel, you can see if the baseline pericardial effusion greater than 10 millimeters, it will be very strong signal to predict non-response. So once we got some knowledge from RD, but PADN is totally different from that procedure too. So this is the first trial to tell us how to highly select the patient before the PADN procedure. In the middle panel, you can see by 3 months follow-up, there was no further reduction in pulmonary vessel resistance. I think this is the key, is a good point to identify to predict the long-term clinical outcome for any patient with any etiology of pulmonary hypertension. So I think we appreciate all the study group to collect data, particularly hemodynamic data, to provide very strong evidence to show the real treatment effect of pulmonary artery denervation for patients. On the right panel, you can see by 1 year follow-up, all-cause mortality rate was less than 15%, mostly driven by the non-pulmonary hypertension, non-heart failure reason. After that, this is our brief introduction of PADN 5 trial. In this analysis, we only include patients with heart failure with combined post and pre-capillary pulmonary hypertension. It means the PVR would be greater than 3 unit. From the table, you can see from the echocardiographic follow-up in the same group, there was nothing different changed. But in contrast, in the PADN group, compared to all the values at the baseline, by 6 months follow-up, several parameters, including systolic pulmonary arterial pressure, left atrial diameter, left ventricular diameter, as well as a E or E plumb ratio, also improved very significantly. Particularly, from the table, we are very, very afraid of the increase all the worsening of the ventricular contractile function, because following the reduction in pulmonary arterial pressure, if the cardiac function could not be improved much more proportionally, so there will be that would make patient at high risk of pulmonary edema. Luckily, from the table you can see in the PADN group, so by 6 months follow-up, the percentage in increase of left ventricular ejection fraction increased from 43% to almost 48%, with very significant p-value 0.031. Again, from the hemodynamic data via right heart catheterization, I think similar and consistent findings with the echo results, including the significant reduction in systolic pulmonary arterial pressure, mean pressure, also increased the cardiac output, cardiac index, as well as the PAC. PAC means pulmonary arterial compliance. So it's a composite, integrated parameter for the remodeling of pulmonary artery. Because, basically, we only include patients with CPCPH. So I think these are very, very important results. Right now is guiding the new design for FDA global trial, because we are very confident about the significant improvement in hemodynamics. Following the primary endpoint study, we also provide the 1 year or 6 months percentage of the clinical worsening. It's slightly different from the definition of clinical worsening for patients with group 1. For this, also included worsening of pulmonary hypertension in other patients. So it was only 16% in the PADN group compared to almost 40%. So let's back to the 5 years ago with the publication of the COAPT trial. So the annualized rate of clinical worsening was almost 50% in the control group. similar finding from the 3-year follow-up, which was published in the JACC heart failure. So from the figure, you can see compared to the left panel, for 6-month follow-up by 3 years of follow-up. So the overall incidence of the clinical worsening was almost 62% in the sham control group. Once again, so we only provide data from our Chinese population. We try to get some data for population outside of China. This is a pilot study registered in Europe countries. So I provided the dynamic change of the patient with a pulmonary hypertension from European guys. So from the table, you can see immediately after the procedure. So the pulmonary arterial pressure decreased greater than 10% with a significant increase in PAWP. I think this is very, very important, but very consistent results with our previous data. Finally, PVR decreased by 19.6%. Also, my one key member, Dr. Han Zhang, is sitting with us. So she traveled to Europe countries to do more PADN procedure in Portugal, also in the Georgia. So I think so far we have 1 year follow-up data. All the results are very exciting to enhance our trustedness for the treatment effect of pulmonary artery denervation. I think this slide is very important. Right now, our post-LHD FDA-oriented clinical trial multiple sites has been approved by FDA. So by December, I think probably this year, we will initialize the first enrolling of the patient from the United States as well from the Europe. From this study design, you can see greater than 500 patients with heart failure as well as the CPCPH combined post and pre-capillary pulmonary hypertension will be included in the trial and randomized to PADN with a sham control group. The primary endpoint was the cumulative incidence of clinical worsening defined by cardiovascular death, transplantation, requirement of left ventricular assistance device, heart failure rehospitalization after patient worsening. After we finish the 1 year clinical follow-up, so patient in the sham group could be crossed over to the PADN group. It depends on the patient clinical status as well as the physician's discretion. Also, for the first 100 patients enrolled in the trial, we finished the hemodynamic measurements at 1 year. At 1 year follow-up, I think this will be very, very important trial. Will provide two different results. One is the general clinical follow-up result. The second one will be the dynamic change, hemodynamic change from the sub-study. So I think the last slide will show us how to do pulmonary artery denervation. Usually, we only need two projections. One is AP cranial. Second one will be very shallow LLO with cranial. After we have had the angiography of pulmonary artery from the AP cranial, we can measure the diameter of main trunk of pulmonary artery. So finally, we need to identify the exact location. Right now, we only perform ablation at the site A, B, and C3 sites. Once we have finished our box, all tools in our box, we will need to select the diameter of the distal ring of pulmonary artery device. As I showed in the last slides, you can see, so it looks like, distally it looks like a circular ring with 10 electrodes pre-mounted onto the catheter. So the size, the ratio of device to pulmonary artery usually between 1.1 to 1.2. It's big enough, it's large enough to make sure the very tight contact of the device with the intima of pulmonary artery. Once we finish the ablation in less than 10 minutes, we will get the significant change, significant reduction in pulmonary arterial pressure. So ladies and gentlemen, in conclusion, sympathetic nervous system is overactivated in patients with various etiologies of pulmonary hypertension. PADN is pretty easy, user-friendly. We only need to do ablation at the ABC 3 sites. And also the whole procedure is safe and feasible. But according to our previous experience, so the learning curve could be finished by completion of 2 or 3 cases. Thanks for your kind attention. Thank you.